Our story is very exciting. Our division started 10 years ago with one provider, and we've now grown to 3 providers. And the expansion of the expertise that we can offer patients and the complexity of the patients that we see has outgrown the basic infrastructure in which we had or have in place to manage these children. We've outgrown our infrastructure in terms of the documentation for the electronic medical record. It becomes very heavy on entry, and these are things that are not really best for a physician to do. And so we were looking for opportunities, how might we redistribute the work, but things still get done accurately and in a timely fashion, and also where we can minimize mistakes in scheduling and follow through and shall we say, closing the loop and providing that coordinated care package. For instance, many of the patients that we see come from a very long way away. They'll travel to Mayo Clinic to see our group. We may get a stack of outside medical records that's literally about 3 inches thick. And if they come into our practice, in a 30-minute appointment slot, we are dawned with the task of going through those medical records, examining the patient, organizing a coordinated care plan, and scheduling all the other medical providers that we need to bring together to try and help manage this patient. And we were doing this with a team of, 1 secretary and several desk attendants and a few licensed nurse practitioners or RNs, a nurse practitioner and a physician team. And we were finding that our ability to do that with that amount of work, all the anxieties of the families and the psychosocial needs that need to be met, on top of addressing all the medical problems, we just simply were getting overwhelmed in our ability to do that. So what we were able to do was bring the entire care team together. We took members of the secretarial staff, the members of the desk scheduling staff, the members from our care providers and our physicians, and we got all together and partnered with the CFI team so that we could try and understand what is it about the practice that we like, what is it about the practice that works, and where are areas that are kind of, shall we say, those touch points, those things that bring upon frustration with our daily ability to do what we need to do and to do it well. And so then we were able to collate a list of, here's what works, and here are the areas that are challenging. And when we came up with that list, it was very interesting. There were 5 major themes that became apparent. We found that we weren't necessarily working as a cohesive, consistent team. We found we had challenges with scheduling. We had found that we also had challenges with patient flow, meaning right patient, right location, and executing what the plan was. We also found that we needed to start to look at standardizing our practices amongst the providers. We are at prototyping right now, and it's really kind of exciting. So we did do all the brainstorming, the observational research, and now we have what we call the co-design team. The co-design team represents 2 individuals from each of our small subgroups, and we've gotten together to look at what are going to be some of the things that we prototype in terms of implementing and trying to help enhance our practice. I think one of the most surprising things that we found is that when the provider, the physician, is sitting down, so you've seen the patient, you've interviewed the parents, you've come up with a diagnosis and a management plan, and you're interacting with the family and you're making this recommendation, and you have 2 small children in the room, and the parents are trying to concentrate on what the physician is saying, and the parents are also trying to concentrate on engaging their child, and their child is distracted or distraught from the examination or just glad it's over. And so we found that the parents weren't necessarily observing and absorbing all the information that even the physician was trying to provide from them, and it was just complete and utter chaos. And from this observational process, what we're finding is that we need better mechanisms in which we can engage the child in another activity while the physician can concentrate on delivering the information back to the parent. And one of the challenges when we look at the flow of our practice is inevitably you sit down, you talk to a family, and you say, this is the surgical procedure your child needs. You explain the risk, the benefit, the rationale, and what the potential complications are. And they may only hear half of it because they're so distracted. And so one of the other things that we're going to look at prototyping is how might we be able to provide an environment for the parent and the physician to interact, yet distract the child so we can increase the parent's ability to absorb the information. And we anticipate that the downstream effect from this will be tremendous in terms of decreasing the number of phone calls back to the provider after surgery, or the number of phone calls back to our office in between the time we see the patient and the time of the surgery. We also feel that it will be able to better engage the parents in the education in terms of what they need to do to manage and take care of their child after surgery. And so if we can get into a routine of prototyping these kind of very, standardization, which was one of the themes that we discovered in our observational research process and our brainstorming, of standardizing that, then you can just redistribute the work so it's not heavy on one person to do, and it becomes a very routine thing. For example, like if we were to prototype standardizing seeing a child straightforward, healthy, needs bilateral myringotomy and tube placement for adenoidectomy. I mean, right now with the paperwork entailed, seeing the patient, doing the clinical documentation, it takes me 15 to 20 minutes to do that. The operation itself takes 3 to 5 minutes to do that. So if you weigh the time difference here, it's substantial when you look in terms of a time investment. Perhaps one of the things we might be able to prototype would be we give the parent an ability to enter some information into a repository about the standard questions that I would ask about otitis media. That could be then entered into a computer and I could walk into a room. I'm just designing a prototype in my head here, whereby that information pops up, I could review it with the parent and do the examination, and we could talk about these are the reasons why your child would benefit from having tubes, and then we could have some interactive computer model that would explain the surgical procedure and the process to the parent, which would then take me out of the loop to do that part of it, and then they could have a visual feedback. It could allow them to do that, while we could take the kid and put them in their kid zone and have them distracted. And so I could be on to seeing another patient, yet we're still meeting the educational need for the patient. And so that could perhaps cut down the 15 to 20 minutes that I take to do that part into a physician effort of maybe 3 to 5 minutes, but still accomplish the same thing, whereby then I could move on to doing something else. But we're still providing the same educational goal and the same patient care delivery package. One of the really cool things about prototyping is that you do it, and then you reevaluate whether or not it's working. And so people don't grab onto it and have ownership. Oh, that's my idea and it has to work. The really cool thing about this co-design process and prototyping is that you're bringing all kinds of people together and they're throwing out their ideas. It gives people buy-in. It gives them some idea to say, okay, we're going to try it. If it works, great. And then we're going to improve upon it. And we're going to try it. If it doesn't work, we don't own it. And I think it decreases that inherent risk that we all have of you don't want to do something and fail, which particularly in medicine, none of us want to do anything that's going to be hurtful. And so at least the prototyping allows us to take these tiny steps, evaluate, say does it work, and evaluate and move on.